Well, good evening, everyone. My name is Dr. Leanne Ward. I'm a clinician scientist at the University of Ottawa, and it's my absolute pleasure on behalf of my colleagues this evening to welcome you to this webinar, starting the conversation, what patients and families with XLH need to know. I'm just going to share my screen to start the introductions here. I think as many of you may be aware, this evening's webinar is part of a virtual series. It's the 5th of 6 virtual events that we've sponsored in 2021. The event is put on by the CCCBH, the Canadian Consortium for Children's Bone Health, which is an initiative that educates and empowers health professionals in the care of patients with childhood onset bone disorders. And the affiliate organization, the Canadian Alliance for Rare Disorders of the Skeleton, empowers patients and families living with childhood onset bone disorders. So we're thrilled this evening to be able to put this event forward. We're partnering this evening with the Canadian XLH Network. This has been just a wonderful beginning to the partnership. The Canadian XLH Network has helped us spread the word. They have submitted questions for the webinar that the panelists will address, and together we're just absolutely delighted to move forward. We begin by acknowledging that the land on which we gather is the traditional unceded territory of the Algonquin Anishinaabe people. The Algonquin people have lived on this land since time immemorial. We're grateful to have the opportunity to be present in this territory. Our moderators this evening of the panel discussion are Doctors Melissa Fiscaletti and Ted Vassarelli. Dr. Fiscaletti is a clinical assistant professor of pediatrics and a clinician scientist at the Université de Montréal, Saint-Justin Hospital, and we're delighted that she's able to co-chair the panel with Dr. Edward, as I said, Ted Vassarelli. Dr. Vassarelli is an associate professor in the Division of Orthopedic Surgery at the University of Western Ontario, where he's the head of the arthroplasty unit at the London Health Sciences Centre, University Hospital. So we have a medical moderator and we have a surgical moderator, which I think is appropriate in this condition. I'll be talking a little bit tonight about XLH and how we diagnose it. Our keynote speaker is Dr. Eric Mel. Dr. Imel is a professor of medicine pediatrics at Indiana University School of Medicine. So he's dual board trained in pediatrics and medicine, which provides a really interesting perspective on rare bone diseases indeed. And we're just thrilled to have Dr. Imel with us. These are some of the members of the Canadian XLH Network that we're working with this evening: Spencer Christensen, Sherry Van Vuckt, Josie Campbell, and Carly Van Art. And you're going to be hearing more from these individuals shortly, and we've appreciated their hard work in helping to put this together. So what can you expect from this webinar this evening? Well, hopefully you'll hear some new information about XLH and its diagnosis and management. This is also an opportunity to brush up on some old information if you already come to the webinar fairly informed. We hope that you'll have your questions answered. We hope that you'll learn about what we as healthcare providers have yet to understand, what the knowledge gaps are and the unmet needs from a knowledge perspective. And then we also hope that you will all, the panel included, as well as the viewership, share with us your thoughts, your experiences, and your feelings. So this is indeed meant to be a dialogue with all of you this evening. This is the outline for the webinar. Sherry Van Vuckt from the XLH Network is going to say a few words in a moment. And as I said, I'll give a talk on XLH and how it's diagnosed. And then Dr. Imel will specifically address the treatment options for this condition. I mentioned that Drs. Fiscaletti and Vassarelli are the moderators, and then the panel discussion will be joined by Josie Campbell and Carly Van Art, in addition to Dr. Imel and myself. So how are you going to pose your questions during the panel discussion? So first of all, you can raise your hand live on Zoom, the little hand button, and the moderators will see that. You can post your questions in the Zoom Q&A. And we have also received from the Canadian XLH Network pre-submitted questions that Drs. Fiscaletti and Vassarelli have access to. So lots of ways to get your questions heard. We encourage you to use your Zoom desktop application instead of your browser, and be sure to distinguish the Q&A button from the chat button. The chat is where you socialize. The Q&A button is where you post your questions. I'm grateful to the CCCBH and CARDS 2021 Virtual Series Planning Committee as well, and they've helped develop the program for this year, including this event. So thank you to everyone on the planning committee. And these are our sponsors. We have received funding from Parent Project Muscular Dystrophy, Ultragenics, Alexion, and we're sponsored by the Ottawa Paediatric Mental Health Research Group as well, via unrestricted educational grants. And so with that, I'd like to introduce Sherry Van Vuckt, who is going to say a few words. Sherry is the chair of the board of directors and a founding member of the Canadian XLH Network. Her daughter Alice was diagnosed with a spontaneous case of XLH in 2008 at the age of 4. Her family's been involved in the XLH community since 2011 after attending the first XLH day in New York State all those years ago. So Sherry, really great to have you with us this evening, and thanks for opening up the webinar.
I'd just like to say thank you again to Dr. Ward, to your CCCBH and CARDS for involving our group in this seminar, in this webinar. It's a real honor for us to be here tonight. I'd also like to thank our social media committee for their work in getting the message out about tonight, and for soliciting our XLH community for many of the questions that will be discussed here tonight. I'd like to just talk a little about who XLH is. So the Canadian XLH Network officially formed just over a year ago. We're a group of about 12 volunteers, both XLH patients and caregivers, who have come together to bring awareness of the specific needs of the Canadian XLH community and to advocate on their behalf. Our mission is to work as a collective to raise awareness surrounding XLH and advocate for patients to ensure all Canadians have access to the best possible treatments, to promote education amongst healthcare professionals, affected families, and the public surrounding XLH, to collaborate with other like-minded organizations, and to support affected individuals across Canada and their families to ensure they are coping and have a better understanding of the disease. So thank you again, Dr. Ward, for having us here tonight. We're, again, as I said, very excited to be here.
Well, thank you so much, Sherry, for that kind introduction, and indeed for starting the conversation. It is so great to be able to partner with the Canadian XLH Network on this webinar and future activities, and we're just delighted to have you and other members of the network here with us this evening. I'd like to start by telling you about my disclosures. I've participated in clinical trials with Ultragenics, and I've been a consultant to Ultragenics on the design of their clinical trials with funds to my institution, the Children's Hospital of Eastern Ontario Research Institute. So I do very much view this as a dialogue. This evening, Dr. Imel and I are going to be giving some short talks, myself on the diagnosis and background information about XLH, and then Eric on the management itself. And then we so look forward to hearing your thoughts about what we say and also what you want to talk about. And again, this is just the beginning of the dialogue. So what causes XLH? XLH is caused by a difference or a typographical error in the PHEX gene. I'll talk more about PHEX in a moment. What is a typographical error or a difference? Well, we used to call that a mutation, but now we call it a variant. And when there's a variant in our gene, and remember that our genome is full of variants, and that's what makes us individual from one person to another. Sometimes those variants can cross over into causing conditions and be pathogenic. So we now think of these typographical errors or differences as being pathogenic variants. The PHEX gene is located on the X chromosome. Remember, there are 22 pairs of autosomes, and then there's our sex chromosomes that give us our male or female status. So boys have one X and one Y chromosome, and girls have two X chromosomes. And the PHEX gene lives in one of the two X chromosomes in the case of a girl, and on the single X chromosome in the case of a boy. PHEX stands for phosphate regulating endopeptidase on the X chromosome. And you'll recall from perhaps science classes in high school that anything that ends in an ASE is an enzyme which is responsible for snipping or cleaving or cutting other molecules. So the PHEX gene provides the instructions for the body to make an enzyme, and the enzyme is then responsible for breaking down other molecules like osteopontin so that they don't accumulate in too high quantities. When PHEX isn't working optimally, then the enzyme isn't working optimally, and these other molecules like osteopontin can accumulate and thereby prevent adequate skeletal mineralization. PHEX is also needed for the overall health of the osteocyte. Now, the osteocyte is the master bone cell. I think of it like the conductor of an orchestra. It is responsible for coordinating all the bone cellular activities. So the PHEX gene is important for the development of a normal, healthy osteocyte. When the PHEX gene has a pathogenic variant, then the osteocyte is not functioning optimally and it overproduces a hormone called FGF23. So the skeleton produces a hormone, which means the skeleton is an endocrine gland, which is pretty neat because the definition of an endocrine gland is one that produces a molecule that then acts elsewhere. So the skeleton produces FGF23 in excess quantities. FGF23's main target is the kidney. It goes to the kidney and it prevents the kidney from holding on to phosphate. And that causes low phosphate in the blood. And we call that hyperphosphatemia, meaning phosphates being peed out excessively in the kidney. FGF23 also impairs vitamin D synthesis. And normally vitamin D production helps to keep phosphate levels up in the blood. So FGF23 does two things that interfere with the body's ability to maintain normal, healthy phosphate levels. On the right, you can see my schematic. You'll often see in talks, people use this bucket analogy where the bucket is the kidney and the hole is created by FGF23 and the water coming out is phosphate, so just being peed out excessively by the kidney. So when the PHEX gene has a typo, then there are challenges with mineralization of the skeleton causing rickets and osteomalacia. And we'll talk about that more in a minute, and causing dental abscesses as well. So what is rickets? First of all, rickets is a term that we do not use in the adult context. Adults cannot have rickets because they don't have growth plates. Children can have rickets. So rickets is the inability to mineralize the growth plate. So it's no surprise that growth delay is characteristic of XLH. Now, there are many, many different causes of rickets, including low calcium in the blood, but that's not the main problem in XLH. The main problem is the low phosphate levels, which I just talked about, and the inability to synthesize or to produce adequate amounts of vitamin D to also try to bring up the phosphate levels. This is what rickets looks like. You can see here, this is at the wrist of a boy who's about 1.5 years of age. He's been newly diagnosed with XLH. He's lacking the necessary phosphate to mineralize the growth plate. Where you see the arrow, the growth plate is splayed. It goes out, it's widened, and it's frayed. And then once he's treated, the growth plate looks much more crisp and healthy and mineralized there on the right where the arrow is pointing. Now, osteomalacia, I consider the bone tissue corollary of rickets. Both children and adults can have osteomalacia, and it is an inability to mineralize bone tissue instead of growth plate, as in the case of rickets. Again, a low calcium can cause osteomalacia, but that's not what's going on here. Low phosphate and low vitamin D levels, which normally help bring the phosphate up, are the causes of the osteomalacia. This is what osteomalacia looks like under the microscope. So on top before treatment, turquoise is mineralized bone like hardened cement, and the red is osteoid or unmineralized bone that's accumulated because of the lack of phosphate, and it's like wet cement. After treatment, you can see the wet cement, the osteoid, has undergone mineralization, and it's become mineralized bone that you see now in turquoise. So in the healthy setting, you should only see a thin osteoid seam, a thin rim of red, such as you have here. What are the consequences of osteomalacia to the patient? One of the main consequences, in addition to bowing deformity, is fractures. Now, you'll often hear osteomalacic fractures referred to as looser zones, insufficiency fractures, or pseudofractures. The only reason we use those special terms is to signal to people that these are due to osteomalacia, due to lack of phosphate in this case. It doesn't mean that they're less painful or any less serious than a fracture that someone would sustain after a fall or some other traumatic event. How is X-linked inherited, XLH inherited? It is inherited in an X-linked dominant fashion that goes like this. If mom is affected with the condition, then there is a 50% chance of her passing on the chromosome, the X chromosome with the FEX variant, right? So that means that each of her children, irrespective of their sex, whether they're boys or girls, will have a 50% chance of having the condition. Now, in fathers who are affected, the situation is quite different. So he does not give an X chromosome to his sons, and he always gives it to his daughters. So all of his daughters will have XLH because he's given the chromosome that he has with the abnormal FEX variant in terms of his X chromosome, and none of his sons will be affected. How often does XLH occur without a family history? This is a question that I often get. 80% of the time there's a family history. And the typical story is that a parent who has XLH will call and say, I'm having a baby and I'd like you to assess the baby, Dr. Ward, so that we can determine if the baby has XLH. 20% of the time, though, there is a de novo pathogenic variant or a spontaneous pathogenic variant, as we call it. So the family is not aware, and the child will show signs of bowing deformity around the time of weight bearing. Often parents scratch their heads and say, not sure if that's normal, but toddlers do walk with a wide-based gait and they waddle a little bit, but over time it becomes more clear that it's out of keeping with what would be normal physiological bowing of childhood. So what are the signs then of XLH in a young child? So a large head is one sign. Babies, of course, have a disproportionately large head than older children and adults, but the head shape is abnormal as well. It's more front and back in terms of its dimensions. That's called dolichocephaly. And then falling off the growth curve, as we say in the first couple of years of life, is a classic sign, as you can see here. We've talked about the bowing of the legs that, as I said, appears usually around the time of weight bearing, but walking can be delayed in XLH as well. And then dental abscess is another sign of the condition that can appear in childhood. You might be interested to know that there are normal growth curves for patients with XLH. So this is an example in boys and girls where the thick blue or pink lines represent the typical growth pattern of children without XLH. And then the black lines on all of the curves represent the typical growth pattern of children with XLH. So we now have this new information as well to guide us in understanding whether our patient with XLH is growing typically for the condition or not. The lower limb deformity that I showed you earlier is also shown here. And even with meticulous medical intervention on the left, we can still see bowing deformity. And so once the rickets and osteomalacia has been treated optimally and the blood work has improved, we look at the patient and say, yes, there's still some residual deformity, and we can help that with surgical intervention done by the orthopedic surgeons. This is called growth-guided surgery, or hemiepiphyseodiesis is the medical term. In the case of a bowing deformity with the knees going out, then 8 plates are put on the outside of the knees, until they straighten up, and then they're removed and the improvement is evident here. The timing of the insertion and the removal is really important, and so that's done in consultation with an orthopedic surgeon. It's only possible to do this during growth, so there's a critical window of opportunity there. What are the signs that an adult might have XLH? Well, certainly pain is a very common feature. Adults will report stiffness, so they're sitting on the couch watching TV and then they get up and they're stiff for a few steps until they loosen up. Short stature and bowing of the lower extremities is also a feature, and then dental abscesses is a problem in adults as well. So certainly adults can present with manifestations later in life. Now, it doesn't mean that the disease started later in life. It means that it came to attention later in life. This is a childhood onset condition, but the condition can be so mild that it escapes detection during childhood. And this is an example of a 34-year-old man who was diagnosed with XLH as an adult around the time that his toddler was being diagnosed. And he has this insufficiency fracture I talked about earlier, also called a Looser zone. Features include, as we said, short stature, bone and joint pain, stiffness, lower limb deformity. Muscle weakness is a major problem for patients with XLH because phosphate is important for muscle strength. And then hearing loss, an associated condition called Meniere's disease, and tinnitus, or ringing in the ears, are also features of XLH. Again, some more of these fractures on the left. This is a more complete fracture than the ones I've been showing you so far. This is similar to the other examples that I gave you. And then there's a diagnosis called Anthopathy, whereby the ligaments and tendons become mineralized. This is a facet of XLH. It usually appears in adulthood, in early and mid-adulthood, if not earlier, and can cause significant stiffness and also pain. So mineralization of tendons and ligaments often around the joints. What about the teeth? For some families, they say to me, you know, the bones are one thing, but the teeth are the biggest problem. And indeed, this is a significant issue for some patients. When there is adequate phosphate, the dentin mineralizes normally and is of a certain thickness, and then the pulp chamber isn't particularly large. In XLH below, because of the lack of phosphate, there's thinning of the dentin with enlargement of the pulp chamber, and that's a portal of entry for microbes that cause then the dental abscesses of this condition. How do we diagnose XLH? Well, certainly we do a blood test. We look for low phosphate. We look for an elevation in an enzyme called alkaline phosphatase, which is a hallmark of rickets and osteomalacia in children and osteomalacia in adults. We look for a normal calcium. The PTH is usually normal. When your phosphate is low, your 125 vitamin D, your active form of vitamin D, should be very high. When it is not, that's a sign that FGF23 is too high and it's holding back the synthesis or the production of 125 dihydroxyvitamin D. So a normal or low 125 vitamin D, when your phosphate is low, is abnormal and signals XLH and other FGF23 mediated forms of hypophosphatemia. High phosphate in the urine is another sign that we look for. We look for the rickets and osteomalacia on X-ray, and we're fortunate in Canada to have genetic testing available to us most of the time, and so we look for these pathogenic variants in FEX. And so my take-home messages for you today are threefold. First of all, I think it's critically important with XLH and other childhood onset rare bone disorders to find a doctor who understands XLH or is willing to learn. I think we all recognize that it's not possible for all doctors to be experts in rare bone disease, but we're looking for collaborating physician partners who are willing to learn, and we're happy to guide them and also to see patients with this condition, of course. I think it's really important that if you're having specific pains or specific concerns about your condition, that there should be a very specific diagnostic approach. For example, leg pains could be those pseudofractures, or it could be an enthopathy. And that needs to be teased out. There are other possibilities as well. And then my other tidbit to take home is keep sharing your concerns. It's by listening to you that we as physicians understand what's most important for you, and we can tailor our engagement and diagnosis and treatment to what's important to you in the trajectory of your condition. So let's all keep helping each other indeed. So I appreciate the opportunity to walk you through that aspect of the webinar. And it's now my pleasure to introduce Dr. Eric Mel, who I referred to earlier, but I want to tell you a little bit more about him. Dr. Imel is a professor of medicine and pediatrics at the Indiana University School of Medicine, whose clinical and research focuses on bone and mineral disorders, especially rare bone disease, including XLH. His unique background, as I said earlier, includes dual training and certification in both adult and pediatric endocrinology at the Indiana University School of Medicine. He's conducted clinical and translational research in both rare and common MSK disorders, including clinical trials of XLH. And in fact, he's been involved from the beginning, really, in the clinical trials that have led to novel therapy in the treatment of XLH across the ages. So he has a very unique and rich perspective indeed, and he's a member of the Scientific Advisory Board for the XLH Network in the United States. So Eric, just an absolute delight to have you here this evening with us, and thank you so much for talking to all of us about the management of this condition. Eric.
Thank you, Dr. Ward. I am pleased to be able to share with you today about medical treatments for X-linked hypophosphatemia. Here are my disclosures. The first thing we need to talk about when we're talking about treatment medically of X-linked hypophosphatemia is what are the treatment goals? And so I think we can pretty much universally agree that we want to improve the osteomalacia, or the abnormal mineralization within the bones, but also improve the growth, the rickets at the growth plates in growing children, and the lower limb deformities that commonly follow that. As a marker, we look at a blood level called alkaline phosphatase to make sure that we're improving that. That's a marker for rickets. And I also like to see improvements in bone pain if a patient's having bone pain, that we decrease the occurrence of fractures or pseudofractures and improve their healing, and also improve healing after an orthopedic surgery, because dental abscesses are also a major problem with XLH. I like to see if we can decrease tooth abscesses, although as you'll see later, there's some question about how effective our medications really are at doing that. And we also want to avoid complications. So to start with, as Dr. Ward will have discussed, our kidneys in XLH are sort of like a leaky bucket, and they're leaking phosphorus. And it turns out that our treatment approaches for the past 30 to 40 years have really been about trying to fill that bucket to a higher level by putting more in it. So there's my little pill bottle here, and it's really pointing at the faucet that's putting water into this bucket, or in this case, phosphorus into this bucket, but the bucket's still leaking. The conventional treatment has been a combination of high doses of active forms of vitamin D, such as calcitriol, plus phosphate salts. And these are sort of general dose ranges for doses throughout the day. They have to be split and spread out throughout the day in order for them to have their most optimal effect. But I also think it's important, and something that doctors sometimes don't understand, is that you can't treat this with phosphate salts alone. There's two big reasons. The first one is it doesn't work. And the other one is that it really tends to enhance the problems of phosphate when you're just trying to treat with phosphate salts alone, in particular complications such as nephrocalcinosis and hyperparathyroidism. There's a lot of laboratory monitoring that's required with this. I monitor my patients every 3 to 4 months once they're stable on therapy, and more often before that. And you have a lot of things to look at to try to guide whether you are increasing or decreasing either the calcitriol or the phosphate to optimize management. So it's very complicated, and it's not surprising that most of the primary care doctors, for example, will have no experience in understanding and doing this. And that's okay, because it is complicated, and that's why a specialist is needed in managing this. Calcitriol and phosphate do have beneficial effects on rickets and growth. Otherwise, they wouldn't have been our standard of care for the past 30 plus years. And as some additional lines of evidence, besides the fact that this treatment does improve the mineralization of the bone on bone biopsy studies, the growth is actually better if you start this earlier, especially before 1 year of age, compared to the kids who start after 1 year of age. And another really important factor comes from the randomized controlled trial that we did in children comparing the new medicine burosumab to calcitriol and phosphate. So it turns out in this study, children were only eligible to participate if they were already on conventional therapy for at least a certain period of time. Most of them were on it for over a year. And they had to have at least a certain degree of rickets severity still. And that was partly so that we could show whether there was an actual difference in the treatment arms once we randomized them. But it turns out that almost half of the patients screen failed, meaning they didn't qualify to be in the study because their rickets wasn't bad enough. And that's actually a pretty good evidence that calcitriol and phosphate are having some beneficial effects. Although admittedly, as you all will be well acquainted, the response is actually highly variable, especially in terms of the skeletal response to this medicine. And I do think of this as a medicine, not just as a vitamin supplement or a phosphate supplement. I think of this as a pharmacologic medical therapy, and that's partly because there are risks that you need to monitor for. And these include gastrointestinal side effects, upset stomach. Phosphate's a laxative, and so when we're asking patients to take a laxative 3 to 4 or sometimes 5 times a day, they might not be super happy with that. I tend to see adults noticing this symptom more than children, but that's an informal observation. Hyperparathyroidism means that parathyroid glands in the neck are overproducing a hormone called PTH. Now, PTH is supposed to be regulated to keep your calcium in the normal range. And the phosphate doses that in particular tend to trigger a secondary response to raise the PTH because the PTH is trying to keep the calcium normal. However, up to a quarter or up to a third of adults with XLH will actually get the parathyroid glands overactive enough that they're actually driving the calcium higher than normal. And high calcium causes its own set of problems that we don't want to have. And so that often requires a surgery. Sometimes there's a different medicine we can add, but it usually requires a surgery for definitive therapy, but also recurs sometimes after surgery. You can get high calcium in the blood or the urine, either from the calcitriol or from the PTH being too high. And as a result, nephrocalcinosis, which is actually deposits of calcium and phosphate in the kidney tissue, can occur in over half of patients. Chronic kidney disease has an unsure incidence in XLH. We know it happens at some. The severe forms are pretty rare still, but the exact incidence is not entirely clear. But this is one of the reasons why we are concerned about limiting nephrocalcinosis. So again, calcitriol and phosphate are pill forms of medicines. You can get liquid forms, but the treatment doesn't target the FGF23 itself. It targets the downstream levels, the downstream problems caused by high FGF23. It doesn't change the FGF23 levels. And because you're still leaking phosphate, you're really unable to effectively or safely target normal serum phosphorus levels. And there's a variable skeletal response, as I mentioned before. So that led to the studies to try to find what we hope is a better therapy, which is burosumab. Now, burosumab is medicine that targets FGF23. It's a monoclonal antibody, which is sort of a programmed immune protein that we programmed to target FGF23 itself. So it doesn't actually act on the immune system in any way. It just binds FGF23 and makes it not have the downstream effects of excess FGF23. And because of this, we actually can target normal phosphate levels. So for example, do you remember this bucket, that's the leaky bucket? The pills in red here will increase the amount that you're putting into the bucket. So there's a thing called TMP over GFR. So it really is just short for assessing how your kidneys are dealing with the phosphorus. And this number is, if this number is low, below these dashed lines, then it's inappropriate and it's too low. And you can see that conventional therapy with calcitriol and phosphate do not correct the phosphate leak like I indicated before. However, the injected burosumab does. We give it every 2 weeks, and you can see the phosphate transportation is actually coming up into the target range, which is a good mode of action. And the result of this is on the serum phosphorus graph here, you can see in red, the conventional calcitriol and phosphate don't really raise the serum phosphorus that much. But when we inject the burosumab every 2 weeks, it does come up very well. Now, some of these numbers are, or some of these data points are at 1 week after the dose, and some of them are at 2 weeks after the dose, and that's why you have some variability here. But we treated these patients for 64 weeks. And you can see on this graph on the right here, we wanted to look at rickets. So just to explain this graph, a 0 would be no change compared to their first visit before they started treatment. So negative numbers would be worsening, and positive numbers would be improving. And values of +3 would be complete and total healing of rickets. And you can see that at both 40 weeks and 64 weeks, the injections of burosumab improved the rickets at the growth plates more than the conventional treatments did. This also improved the bowing and lower limb deformities, although that magnitude of effect was smaller and lagged behind in time. So we can change the effects at the growth plate faster than we can change effects on the curve or bending of the long bones. And of course, once the bending gets to a certain degree of severity, even if you fix the health of the bones, they're not necessarily going to straighten out. So this is a reason, again, to start on at least some medical therapy for XLH at a younger age, because maybe you can prevent some of that. So we also did a randomized controlled trial in adults. And in adults, we compared getting the injection that had burosumab in it to getting a placebo injection, or an injection that did not have active medicine in it. And it also improved the phosphorus as expected. But about half of the patients had active fractures or pseudofractures. Now, what's a pseudofracture? A pseudofracture I show here in the tibia. This is somebody's right tibia, and I blew it up here so you can see a little bit better. But you can see this little area that looks like almost like a bird's beak and a line in it. And it's sort of like a stress fracture. I don't know why we don't call it stress fractures. A long time ago, someone chose the name pseudofractures for it, which I think is unfortunate because it might make some people think, well, it's not a real fracture, it's not a real problem, but it's a very real problem and is often the source of pain. And sometimes it's a place where somebody breaks and fractures all the way through. So by week 24, if you were on placebo, you didn't really change your healing of those active fractures and pseudofractures very much. But about 40% actually had completely healed their active pseudofractures and fractures. And once everyone was on burosumab in the last half of the study, they had ongoing healing in both groups. But I do want to note that even after 48 weeks of burosumab, it was only about 2/3 of the patients that had completely healed their fractures and pseudofractures. And so is that a success or a failure? I actually think that it's a success because it's an improvement overall in the healing. But it also means we have to recognize that a lot of times when these develop, they're present for a long time before they're even detected. Because if somebody is having frequent leg pains, they might not notice that the pain is worse or worsening because it's often gradual. This isn't a situation where you're just going out and like a marathon runner who's knows they're training excessively, and then suddenly they get pain, and you have a pretty good idea when it, roughly when it may have happened. For patients with XLH, I think often they don't really know when it happened because this has been a more gradual onset, and because the underlying osteomalacia contributes to bone pain, even in the absence of things like this. But this has led me to start doing lower limb x-rays when I first meet an adult with XLH, as well as children, but also if there's any hint of worsening pain. So what do we not know about burosumab? I think this is really important because it helps both manage expectations, but also to recognize the things we need to study more. So what about growth? There is some data that growth is modestly improved on burosumab compared to being on conventional therapy. Certainly, patients with XLH, with or without conventional therapy, do on average have significant impairments in height growth. And that's why a lot of adults are frankly short as adults with XLH. So even though we've seen over relatively short-term studies some improvements in growth, we actually haven't treated anybody through their entire growth period. And so we don't actually know what the effect on final adult height is. What's the full magnitude of effect on the height, but also on the degree of lower limb deformity, especially when we start treatment at very young ages. And I'm really hopeful that starting treatment at young ages will maximize the effects. What about teeth? So dental abscesses and gum disease are really common in patients with XLH. Over 2/3 of adults have problems with this, at least to some degree. There's some evidence that treatment with calcitriol and phosphate might decrease the occurrences of dental abscesses, but as you all will know very well, they by no means eliminate it, and they remain very common even despite conventional therapy. So for burosumab, it turns out, although I would like to say that it improves these things, we actually have no evidence of that. And in fact, in the clinical trials, in the burosumab group, there were more tooth abscesses events in the burosumab arm than in the conventional therapy arm or in the placebo arm. I'm still hesitant to say that it makes it worse because I'm not really convinced of that, partly because, again, these are still relatively small studies of sort of sporadic events over really short time periods. And so something may look like it's more over the course of 6 months or a year, but over the course of several years, does that really pan out and continue to be the case? And I think we just don't know. Kidney calcifications, again, are an important complication of calcitriol and phosphate. Theoretically, the risk might be potentially lower with burosumab based on the fact that it changes the way the kidneys are handling phosphorus. Although if you drove the blood phosphorus level too high, that actually is an independent risk for nephrocalcinosis in patients without XLH. So we don't actually know, is the risk the same, less, or more with burosumab versus conventional therapy? I think it's probably not going to be more, but it may still be the same. And so you still need to monitor people's kidneys. Again, I said hyperparathyroidism is very common in XLH. And when it causes high blood calcium levels, it requires surgery as a definitive therapy. Hyperparathyroidism is worsened by phosphate, while the calcitriol can help with it unless the calcium is already high, because again, calcitriol also raises calcium. Burosumab should not have the same risk of hyperparathyroidism based on how it works. And it might actually improve the hyperparathyroidism, at least for those who don't already have a high blood calcium level. I tend to think that once you have a high blood calcium level, though, burosumab actually will probably not help this. and theoretically could worsen the calcium during parts of the dose cycle. I haven't actually seen that, but it's a hypothetical risk, and I like to use all of my brain when I'm thinking about my patients and trying to make sure they're safely cared for. What about joint complications? So a lot of the problems that adults with XLH are having relate to pseudofractures and bone pain, but a lot of it actually also relates to something called anthopathy, which are calcifications, like you can see along the spine here, that extend between the vertebrae here or over here on the hip. They can cause spinal compression in some patients if the calcifications are in the back part by the spinal cord. And also you get a lot of osteoarthritis. So it turns out that there's no evidence that any of the medications we've ever used for XLH impact any of these. And that's true for conventional therapy. We have no evidence that it helps any of these things. And we've been using burosumab even less amounts of time. And because these are things that develop over the course of many, many years, we really don't have any evidence that using burosumab improves or would improve these factors. And so I often tell my patients some of the pain may improve, but not all parts of it. Restless leg syndrome is important. It occurs in about 8% of XLH patients without burosumab, but it does clearly increase with burosumab. Sometimes it resolves over time, but it often increases with burosumab, and we don't really understand the reason for that. And then finally, pregnancy and lactation. So it turns out burosumab does cross the placenta, and we have very little data about safety in pregnancy. What I would say is we actually have very little data that calcitriol or phosphate are needed in pregnancy either, unless mom is having bone problems like stress fractures or pseudofractures. And it turns out that before the baby is born, even if the baby has XLH and even if mom has XLH, the baby's phosphorus is normal. Now that's based on an animal model, but it's probably true in the people as well. So we do have evidence that burosumab improves the osteomalacia, the rickets, leg deformities, growth, bone pain, fracture healing. I didn't talk about it, but there is some improvement in muscle weakness as well. Several of these things are also improved by calcitriol and phosphate. And so I know this has been a brief whirlwind tour, but hopefully this helps you navigate just some of the recent thoughts about medical treatment for XLH.
Great. Thank you so much, Eric, for that wonderful talk. That was really informative and thorough, and you covered a lot of ground. So thank you. Really good springboard now to the panel discussion. So the panelists are all going to join me now, and I'll just introduce everyone, and you can put up your hand and wave as I do that. So I've already talked about Dr. Ted Vassarelli, representing orthopedic surgery this evening. Hi, Ted. And Dr. Melissa Fiscaletti, representing the medical side of XLH. So Dr. Fiscaletti and Vassarelli will chair the panel discussion. And then we have two representatives of the Canadian XLH Network. First, I'd like to introduce you to Josie Campbell. Josie, do you want to say hi? There we go. Josie gave me this bio to tell you about her. She says XLH has always been part of Josie's life. She inherited the condition from her mother, so subsequently was diagnosed shortly after birth. Her two brothers, 2 sons, and 3 nieces are all affected as well. This has sparked Josie's interest in taking extra measures to advocate for herself, her family, and other Canadians with XLH to be able to receive the best care and medications available. Josie is currently the secretary of the Canadian XLH Network. So great to have you this evening, Josie, and your perspective. Thank you. And then Carly Van Art, there she is. Carly was introduced to XLH in 2016 when she met her husband, who inherited the condition from his mother. Carly became more invested in learning and advocating for XLH patients with the arrival of their daughter in 2020. She's committed to advocating for her family and other Canadians affected by XLH and hopes to provide encouragement to others in the unique position of caring for adults and children with XLH. She currently sits on the board of directors for the network, the Canadian XLH Network. She lives in rural Ontario and works as a communication disorders assistant, providing speech, language, and swallowing therapy for people with acquired brain injury. So great to have everybody this evening. I hope we have some lively discussion, and I'm going to turn it over to Drs. Fiscaletti and Vassarelli to kick off the panel discussion with a question. And participants, you can pose your questions in the Q&A. We won't be monitoring the chat, but we will the Q&A.
Well, thanks so much to Dr. Ward and Dr. Imel for those great overviews on diagnosis and treatment. So I'm just checking the Q&A. There's nothing coming up right now, and I don't see any hands up. So I encourage anybody who has a question to either raise their hand or post it in the Q&A. So we'll go to the pre-submitted questions from the XLH Network. The first question, we'll start off with you, Dr. Ward. Do some patients with specific gene variants or mutations require different amounts of medication than other patients? So is there a genotype-phenotype difference in the way you treat some patients with different genetic variants?
Yeah, that's a great question. You know, we don't have a lot of information on that. There is one mutation called a 3' UTR mutation that does seem to be linked to a milder phenotype. But generally speaking, there hasn't been a striking association between the specific genotype and the clinical course. Now, that said, I think we're just really starting to dig into clinical studies on a more population basis in recent years, getting genetic testing more thoroughly in patients, and then starting to better in the research setting quantify their clinical outcomes in terms of pain and deformity and growth and dental abscesses and anthopathy, et cetera. So I think this is something that we're going to learn more and more about as time goes on. Thanks for that question.
Eric, maybe just to build on what Leanne was talking there, aside from the medical management of things, are there anything that can be done on the dietary side that can improve growth and muscle strength and dentition?
So, yeah, I'm on. I think generally speaking, the things to do on the dietary side are the same things that every person should be doing for general dietary health. It turns out that you don't really need to go out of your way to get a high phosphorus diet, because a high phosphorus diet still actually isn't enough to overcome the problem, because frankly, otherwise none of you would be manifesting hypophosphatemia, because the typical diet is very high in phosphorus, and in fact foods are also having phosphorus added to them as a preservative. So phosphates are very common preservatives for a lot of foods, and so just from a dietary standpoint, we're getting a large amount of that. Probably what's more important from the effects of diet on the overall health are diet and exercise to maintain an appropriate and healthy weight. And that's because XLH already does impair a lot of people's mobility. And if you can, I tend to think if you can do things to keep using your mobility, you can prolong the mobility longer. I don't have any studies that actually prove that. But I do know that a lot of patients who with XLH struggle a lot with obesity and being overweight, and that further impairs their mobility, which further makes it harder for them to lose weight. So I actually think that from a heart health and a muscle health and just general body health, starting early on, like all of our children should be doing, everybody should be doing this, trying to build generally healthy dietary habits, but none of them are specific to XLH.
I'm just wondering if Josie has any comments about that. Josie, do you have any dietary recommendations, anything that sort of worked for you to just generally make you feel better? or exercise?
Dr. Ward. We did end up meeting with a dietitian after seeing one of the doctors who recommended it, and they kind of just reiterated what Dr. Imel just said. Our diet was pretty high in phosphate already, and some of the foods that were high in phosphate were kind of surprising. Like I think beer was on the list, and like Coke, Diet Coke. So we chose not to drink more beer or Diet Coke than we were already drinking. So yeah, not a ton in the dietary changes were really helpful to us. But obviously I agree with the just having a healthy diet and exercise, although it is more difficult for someone with XLH. For example, I'm a teacher and I just went back to work. This is my second week back to work, and just standing on the hard floor for more time than usual has been pretty difficult. Like I'm limping at the end of the day. And I know it's something my body will get used to, but it's pretty hard to want to exercise when just standing up for a few hours was pretty tough. So, I mean, we do our best, but it is quite difficult.
Thank you.
Thanks, Josie. So we have a question coming up in the chat from Emmett Morgante. And he says that phosphate is an important component of ATP, which is an important energy source for the body. So what are the effects of XLH on energy levels? And are there any differences between how the disease is managed between conventional therapy and burosumab, and any effect on energy levels? Dr. Mel, have you seen any research data on this?
So that's a very good question. There is data about muscle strength. I think some of the studies in humans about muscle strength, especially lower extremity strength, are a little confounded by the osteoarthritis and sometimes the the bowing of the legs that can throw those studies off. But even in the mouse studies of XLH, the mice have some degree of muscle weakness, and you're exactly right. It has to do with how ATP is being generated and working in muscles. Both patients starting conventional therapy and patients starting burosumab will often note improvements in fatigue. And likewise, when they stop them, they will often note worsening levels of fatigue, both a general fatigue sense, but also a muscle fatigue sort of sense. And that's been somewhat hard to quantify, but we do have some studies definitely showing some improvements in fatigue, as well as some other parameters that I think are partly related to how the muscles are functioning, including stiffness. I think when people, we have some studies showing improvements in stiffness, especially with burosumab, and the time course on it, it makes me think it's really a perception that's based on how the muscles are functioning. It's a subjective assessment by the patients, but I think it's due to muscles.
Yes, I agree. I think we've all had patients who that's the first thing that we hear is the increased energy levels in the children. And I'm wondering, Carly, if for you as an adult, have you had that carry through into adulthood, or what's been your experience with like general fatigue and muscle pain?
So my daughter has XLH, and she started Crysvita when she was 6 months. So when she started, she was still quite small, and it was kind of hard to see what energy was attributed to her taking this Crysvita, or just natural, like is she having a growth spurt, is she teething, that kind of thing. But one thing I did notice is she was just starting to kind of pull herself up onto furniture. But once she would get up there and be standing there for a few minutes, then she was done and she needed to sit down for like an hour, and she was ready to rest. And then once she was on Crysvita for a little bit longer, that seemed to, she had more stamina and she could kind of stand and hold herself up for longer without having to take such a long break. But I don't know if that's developmental or how, if it was affected just by the burosumab. But now she's been on it, so she's almost a year and a half, and her energy level seems to be pretty consistent. Maybe just before she takes her next dose, she might get a little more fatigued, but it's also, she can't tell me that, it's just what's observable. So it's kind of difficult to say. So we just kind of have a communication with our daycare and saying, you know, how was she today and how was she feeling? And then she's also teething and got teeth coming in. So there's a lot of factors, but in general, I think that the burosumab has been helping for her. Yeah. That answers it.
I would say, based on my daughter's experience, and she was saying around 12 years old when she started on burosumab, and fatigue wasn't as much of an issue for her, but proximal muscle weakness was a noticeable deficit that she had before starting therapy, and things such as standing up from the floor, or as Dr. Ward has seen some of the videos of her skating, single leg stance and that sort of thing on the ice has been a marked improvement since being on burosumab for her. So.
Which, by the way, I can't do.
Yeah. You know, how many of us can get up on one skate, you know, from the seated position, from the shooting duck position?
So,
I know my experience echoes what you've just said. I was really struck when we first started a few children on burosumab, and they came back a couple weeks later, and the first thing the parents said was they felt more rested because they were sleeping through the night because of the lack of the nocturnal dose for those families that chose to do that. And then, you know, pretty much universally, the families reported that the children seemed stronger, that they were able to run a little bit better, even very, very early on. And I thought to myself, that really must be muscle, because I would expect that any bone effects would take a little bit of time. So I would agree and echo with what folks have said here tonight about muscles being positively affected here by improved phosphate levels.
So we have another question from the Q&A. Dr. Ward, maybe you can start with this one. So in the presentations, it was discussed that phosphate is a laxative. Are there any phosphate formulations that are better tolerated than others? And do you have any advice for children who aren't able to tolerate phosphate due to the side effects?
Yeah, that's a great question. So fortunately, haven't had many patients complain of diarrhea, but it has happened a few times. And I would say that the phosphate effervescent preparations are more laxative inducing than the tablets. So that's one observation that I've made. And when we haven't been able to switch to a tablet, then I've just adjusted the dose down to the point that the child feels comfortable again, and then upwardly adjusted the calcitriol. And remember that the calcitriol does many things. It certainly helps keep the parathyroid glands in check so that the levels don't climb up inappropriately. But the calcitriol also stimulates intestinal phosphate absorption. So if you have to come down on the phosphate dose, you can counteract that by going up on the calcitriol to stimulate phosphate absorption in the gut. So that would be my recommendation there.
I would agree with that. And one of the things that I often have seen is that doctors will often end up trying to push up the phosphorus dose when I really think their regimen would be more balanced if they had a higher calcitriol dose. So I've often seen doctors, when they get labs, they say, oh, these aren't where I want them to be, so I'll increase the phosphorus, and they just leave the calcitriol dose at a level that I think is too low. And I think they would get more benefit and less of the problems of the phosphate by switching that and being more towards the calcitriol.
Mm-hmm. Yeah, that's my approach too, Eric, is to favor the calcitriol adjustments or higher doses over the phosphate, especially since the phosphate really drives the parathyroids. So I would agree there.
Okay, if we move on to a next question, are there any different stages of symptom levels that people typically experience with XLH? For example, as we age, going into our early 20s, do the symptoms get worse with time? So maybe Josie, you want to speak to your experience with that, and then we can see what some of our other panelists like Dr. Ward or Dr. Imel have seen in their experience.
Sure. Excuse me. For myself, it was just like the question said, you know, in my 20s, I thought, oh, XLH, like, okay, you know, I took those meds when I was a kid. I'm good. Like, this is great. I'm just, you know, living my best life. And then I had a baby, and then I had another baby, and then I, you know, turned 35 this year. And things are really starting to, you know, I don't know if I'm just, everyone feels this way when they get older, but I'm pretty sure this is an XLH related thing. So it really just underlines the fact that taking care of yourself as an XLH patient is so important. Seeing those doctors when something hurts, and you know, that the diet and exercise. But yeah, I would definitely say, just from personal experience, as I'm aging, things are getting harder, things are getting stiffer, things are getting more sore. So yeah, I would agree with that for sure.
And I think that underlines the importance of, like you said, making sure you have that medical follow-up even into adulthood, to make sure that, you know, we're finding out if there's enthesopathy there, or if there's any pseudofractures. Dr. Mel, what's been your experience with your adult patients?
I think this really has, I think this really is a very common story. While some adults, you know, it's quite frequent that adults will have stopped treatment when they're done growing and they leave the pediatrician's office. And some people will start to get bone pain and pseudofractures fairly quickly, like within several months or a year of stopping their prior conventional therapy. But I think a lot of people have more of a story like yours, that they take, it's more gradual, and it takes longer, and I don't know if I don't think it's actually because of having children, although they add to the sleep deprivation. But I think it's getting more into, you know, that stage of your life sort of corresponds to this time where it's been longer since somebody may have been on a medicine. Also, the enthesopathy takes time to develop, and it really mostly starts developing after childhood. And so that's something that's another reason why some of the pains and stiffness may tend to accumulate over time. And we see a lot of things that in the general population, osteoarthritis, you know, joint problems, a lot of these musculoskeletal pains that people think of as going along with old age. I unfortunately have a lot of XLH patients who are in their 30s and referring to themselves as old, which breaks my heart because I'm older than that. But a lot of these things begin at younger ages in patients with XLH. And so having a provider that understands that, I think can be really important.
Now, just to follow up on that, we're sort of talking about conventional therapy and transition to adulthood, realizing that we don't have much experience with it. But what are your thoughts on the children that start taking burosumab? Will they be continuing on this into adulthood, or do you foresee an endpoint to that? And maybe after your answer, we can sort of transition to some coverage and advocacy discussion around the medication as well.
Well, I think you're right that we don't have much data on that. And in fact, the registration clinical trials, the main clinical trials, didn't even cover that age. You had to either be young enough to still be growing, or old enough that you were long past growing to get into the studies. I think when all of this started, I was sort of thinking that we might still we might still be able to apply a similar approach with burosumab, where somebody did maybe stop for a little while when they're done growing to see how they were doing, because occasionally you do have some XLH patients who are doing very well for many years, and that may still be a possibility. I've tended to have a lot of patients, well, a lot, among the patients who have reached that time point in their treatment. I've had a lot of them still actually prefer to stay on therapy, and I've had some of them, when they do stop, really start to notice the muscle and bone symptoms. I mean, it may still take several months, but they've often started to notice it. So this may be something that we may find more people are needing to stay on. But this is sort of not an entirely clear, and the adult dosing is a different frequency than pediatric dosing. We do once every 4 weeks in adults and every 2 weeks in children. And exactly when that transition would occur, if you're going to continue on therapy, has not really been the topic of any studies. My own approach has been to switch, not based on an age, but based on an amount of time since I think they're done growing. So usually a couple of years after they're done, after I think they're done growing, is about when I've been switching them. But I have no data to like drive that. It's just my interpretation of biology.
Yeah, no, and I think it raises some interesting questions in terms of, say, if someone does put treatment on hold, call it, and they do start to develop anthopathies or degenerative joint changes, to what extent those will be reversible.
And I think that's actually a really important point, because I never have told a single patient that burosumab is going to reverse either of those two things, because I also don't have any evidence that it prevents either of those two things. I do sort of think the aspects where I think the degenerative joint problems, for example, might be benefited by burosumab are actually by its effects on the growing skeleton and more on having straighter legs, for example. And so I imagine the wear and tear aspects on joints might be lessened in that situation, but we don't actually have so I don't feel, with the level of current evidence, I don't ever tell people we should start you on burosumab now when you're 25, so that when you're 35 you don't have arthritis or that you don't have, you know, anthopathy, because there's no data to tell us that would happen, that would prevent it. It would be great if it did, but we don't actually have any data to tell us that.
Mm-hmm.
So that raises an important point too about, you know, having access to burosumab for adult patients, and even just self-advocating, I guess, not just for our children and the pediatric community, but also to have access to medical care. Carly, can you speak to any tips that you may give other parents out there that have had some trouble or kind of getting the right kind of medical attention necessary?
Yeah, so I was very fortunate that other members of my family kind of led the way for me in what forms you need, what doctors to go to that can help you, and who are your points of contact to advocate to get the burosumab. So we're on Crysvita through the actual manufacturer of the drug. They have a compassionate care program. But I only knew about that through family who also took that route. So my goal is to help with the Canadian XLH Network, make that available information to everyone that this is a route that you can try. I don't know what they have a limited amount that they can help through that means, but hopefully as a community we can come together, and if we say that this venue is working and that's how I got my medication, that we can come together as a community through the Canadian XLH Network to help advocate for each other, and not just in our own circle, but to make the circle larger for everyone in Canada. And I think it also goes with finding care providers that are either already familiar with XLH or who are willing to learn and willing to do that research with you to try and figure out how you can back up your case and how you can move forward. Go through, if you're feeling that you're having aches and pains as an adult, go get the x-ray check for the pseudofractures, as we were calling them, to support your case, to help advocate for yourself that you do in fact have pain and you do need the management that the proper drug can give to you. I think also writing to your representatives and helping to get the government to help. We've been running a campaign to write to your MPP or your MLA in Ontario or across Canada to try and bring these issues forward so that we can get funding through the government to help get people access that way, because not everyone will be able to get compassionate care access. So just kind of coming together, and if you have a tidbit, sharing it, and hopefully we can come together as a group and help each other. I don't know if anybody else has any other tips.
I would just say that this is certainly being worked on. You know, the ideal situation is that there would be equity in who has access based on who needs it. That would be the ideal, and that would be very much also in line with, you know, the Canadian standard, the Canadian principle. I think we're proud of our national healthcare in the sense that it is, you know, based on equal access types of principles. So it is being worked on, and at the moment, certainly there's a lot of tension on the children getting access, but we need to keep talking about the adults and how they're feeling on therapy, and you know, access for the adults as well. So this is an issue that's unfolding as we speak, and I agree with everything that you said there, Carly, in terms of advocacy and helping each other and keeping the narrative going. And I'm just cognizant of the time here, and I'll just maybe turn it over to Josie. You know, do you want to have the final word before I ask Spencer to wrap up? For the panel, do you have any sort of last thoughts you want to share with us as an individual living with XLH?
I think Carly really summed it up well, but just one point to make: if you have a patient with XLH, I would definitely advise them to reach out. Social media, I mean, is at our fingertips all the time. There's a lot of XLH Facebook groups that were so helpful and continue to be helpful. If you have a question, you're not too sure, maybe you're not feeling super confident in going to your doctor. Sometimes it can be intimidating to ask you guys questions, but social media is really helpful, and people can kind of give you tips. And obviously I would advise you to chat with your doctor after someone gives you some advice on social media. But the Canadian XLH Network is a great group of people, and I would recommend reaching out, or recommending your patients reach out to either the Canadian XLH Network or any other, international XLH networks as well.
Yeah, that's a really great summary, Josie. And I'll just tag on to that, you know, one of my goals, in part through CCCBH and CARDS partnering with the Canadian XLH Network, is to get every patient living with XLH linked to a physician who knows about XLH or is willing to learn. So I think that's sort of one of our big goals for 2022, if you will. I think that's very important in the rare disease space. So thank you for that wonderful discussion. We heard a lot of different views on different issues, and I'm going to just ask Spencer Christensen to say a few final words. Spencer is 32 years old. He lives in Toronto, and he works in venture capital investing in exciting small businesses from around the world. He was diagnosed with XLH before the age of 2 and is the second of 3 generations of XLH in his family, as his mother was a spontaneous presentation, and he has a nephew with XLH as well. Even though Spencer has 3 generations of XLH in his family, growing up with the disease can still feel isolating, and he's going to talk about that a bit more. And so he joined the Canadian XLH Network as a director to try to help raise awareness and bring the community of Canadians with XLH together. So Spencer, thanks for sharing a final few words with us this evening.
Yeah, thanks very much, Dr. Ward. On behalf of the Canadian XLH Network, I'd like to first take this opportunity to thank CARDS for organizing this webinar. Thank you to speakers, Dr. Ward, Dr. Imel, for sharing such valuable information with the XLH community here in Canada. And the moderators, Dr. Bassarelli, Dr. Fiscaletti, just for helping to guide such an interesting and informative discussion. Really enjoyed that. So one of our main goals of the Canadian XLH Network is to kind of help ensure, the best information is available to Canadians affected by XLH, and just to make sure that people can have the best understanding of this disease possible. I think that this, webinars like this is a big step towards doing that, and so we hope to plan to kind of bring more of these in the future. Personally, as someone with XLH, I found this very valuable. I'm really happy to see so many people join the event too. Just seeing the community start to come together. If you haven't already, please visit our website, CanadianXLHnetwork.org. There's some information on there that's helpful, but also links to all of our social media channels where you can engage with other people with XLH, and we try to keep posting information kind of regularly to be engaged with the community, because we find it really valuable too. Really trying to bring people affected by XLH together is one of the big reasons that I started, that I joined the Canadian XLH Network. Growing up with a rare disease, like Dr. Ward said, can be quite lonely and isolating, and have found that having a community of other people to talk to has been incredibly valuable. So finally, I'd like to thank the Canadian XLH community for joining and contributing such great questions that made for such an interesting panel discussion. I'll turn it back over to you, Dr. Ward, to wrap things up. Thank you.
Yeah, thank you, Spencer, for that. And again, we are so thrilled to be able to partner with you, the voice of the patients and the loved ones and the caregivers. So we look forward to this just being the very beginning of a long journey. I've had a lot of fun tonight. It's been great to see everyone. I hope the viewership has learned a little bit, and thank you for contributing your wonderful questions. Ted, Melissa, Josie, Carly, Eric, Spencer, and Sherry, thank you so much for taking time out this evening. And I look forward to the next time we can all be together again to have more thoughtful discussion. So have a great night, everybody. Until next time.